This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
I encountered a very peculiar and surprising situation in one of my cases recently, and it was perplexing. So, intraoperatively, I noticed something like this during nucleus management, and it looked very much like a PC tear. So, let's start. So, this was an unassuming routine case, as routine as one could be. The rexus is done. The hydro procedure is being performed now, the nucleus rotation done. Now is the time to perform the direct chop. The tip is buried into the substance of the nucleus. The vertical chop is being done and the nucleus is divided into two parts. The nucleus is rotated and the subsequent chops are being done. So as I'm doing it, it seems to be going very well. Nothing unusual at all. Now the fragments divided, time to consume them. The first fragment is pulled out of the bag, emulsified. Second piece also is pulled out. Third piece is being done now. And at this point, I'm noticing something unusual. In the distal end of my view, I can see a demarcation line. And this is looking very suspicious. So I'm just stopping for a moment and be sure that my mind is working like crazy. So I'm holding the fragment with my tip and clearly you can see that this semicircular demarcating line, it looks very much like a PC tear. At this stage you can imagine my mind is running like crazy. How can it happen? When can it happen? Why did it happen? Nothing unusual. What should I do now? Now because the followability of the fragment was good and the demarcation line is not very widely splayed open, I'm pretty certain that the PC tear is a possibility, but there's no vitreous prolapse as such. The antihyaloid is intact. So I thought, let me proceed with phacoemulsification. There's an option, was should I come out, put viscoelastic and then proceed? Now because I was convinced that the vitreous prolapse was not there, and if I could maintain the chamber pretty well, I can pretty much emulsify all the nucleus and then come out. So that was my objective of not coming out. Slowly but surely the remaining two fragments are being emulsified. I'm trying to be a little bit slow here. Occasionally I am seeing this flutters in the antechamber again. That is again causing me some concern. This can happen when, apart from the microsurge, whenever there is a posterior capsule tear, there's a communication with the posterior part of the ball. So you have these micro jitters. So that's again is a cause for concern for me. But the last fragment is emulsified. I'm pretty much convinced that the PC tear is there, the epinucleus has come out, and now you can see that clearly the edge of the margin is fluttering. A fluttering edge again is an indication that there is no vitreous prolapse. So at this stage my diagnosis was this is a posterior capsule tear with an antihyaloid intact. So like a good student, before coming out, I'm going to inject some OVD. I just held the cannula there. I'm asking my assistant to inject the OVD and he does. And once the chamber is reasonably filled with the OVD, the phaco tip is withdrawn. So far so good. So I want to go ahead and refill the chamber again and just want to see what happens to that posterior capsule tear. And as I'm pushing my OVD, lo behold, again something unusual happens. The demarcation line has disappeared towards the equator. Rather, it has moved towards the equator. Now, what does this indicate? It got me a little bit perplexed again. Maybe it was an equatorial tear. The OVD has pushed the edges of the tear towards the equator. Maybe there's a reason I'm not seeing well. So I thought the best thing to do now is to put in a lens because there's hardly any cortex remaining. That would be the best approach and deal with the PC tear as it comes. So the plan was to ensure that the haptics are positioned in such a way that the distal haptic and the proximal haptic are all away from the presumed PC tear, about 90 degrees away, and this is the orientation which I am aiming for. The planned single piece hydrophobic lens is gently maneuvered into the eye. The distal haptic has in the bag and it is in the desired position. Now I need to maneuver the second haptic into the bag. So without dialing or rotating it, I'm just negotiating the proximal haptic again into the bag. As is evident from this picture, the haptics are away from the area of the posterior capsular tear, so it looks good. So now I need to remove the viscoelastic. So what happened to the posterior capsular tear? I presume it's still there, hidden in the equator. So I'm just going in with my bimanual cannula to remove the OVD. I'm trying to go in a little bit slow. I have decreased the bottle height to 50 centimeters, load down my aspiration flow rate and vacuum to 15 and 100 respectively. So along with the visco, I just want to remove some of the residual cortex which is there in the bag. As I'm doing this, we can see that the posterior capsular tear, the demarcation line has come back again. So very clear that the fluid has gone, and again probably it is enlarging the PC tear. But surprisingly at this stage, it looks like it is above the intraocular lens. So I'm not sure what is happening here. How can it be above the lens? Very gingerly and slowly I go in with my aspiration cannula, just trying to touch it and see what is happening. And lo behold, the demarcation line just disappeared by gentle aspiration with the probe. Oh, so here was the catch. It was nothing but a cortex which was aligned in such a way that it was looking like a posterior capsular tear. The moment the lens was introduced into the bag, the cortical fiber came above it, but still its two ends were attached. And the moment the aspiration cannula touched it, the cortical fiber got broken and it was aspirated. So this was like a masquerade syndrome for a posterior capsular tear. Even a surgeon who has seen hundreds of posterior capsular tears can get confused by these appearances. So that was a learning for me. But nevertheless, the lessons which we learn from this is whenever we see these pictures which mimic a PC tear, we need to act like as if we're dealing with a PC tear. Take all the necessary precautions. Never allow the chamber to shallow or overinflate, and then assess the situation. So how does a posterior capsular tear look like? This is how it looks like. But in this case, it wasn't the case to be. So that was it. Thank you for watching and hope you found this helpful.